For almost everyone who cares for someone with Alzheimer's, the hardest days come when they at last have to let their loved one go to the more intensive setting of a nursing facility, or when death finally and inevitably comes. It's always a struggle. It is never easy. In this program, we'll look more in depth at this time of transition and meet others who have gone through it. One of the transitions that families with Alzheimer's make involves going from a lifestyle that's active to a routine that may become increasingly isolated from friends and from outside activities that you've always enjoyed. The day may come when it's no longer possible to go out with your loved one. In the meantime, there are ways to adapt activities so you can still enjoy outings and visits with friends.
My mother goes to church with us every time we go, which is usually 3 times a week. And she is fine as long as she is right next to me. If she loses sight of me, she gets in a panic state. Luckily for us, there are a lot of very understanding people there that know the situation and are sympathetic and helpful. Beyond that, we don't have much of a social life, to be honest with you. I do have a brother that takes her 1 weekend a month, and that's helpful, that we try to plan our events on that weekend. I can take her to the mall, and I can take her to lunch, but beyond that, that's about all we can do.
A lot of the things that we did together we couldn't enjoy because like a movie or going out, almost as soon as he would get there, he'd be ready to leave. So those things we couldn't do too much anymore. Mainly the things that we could do would be outdoor activities where you might just walk around or go to a park, or indoors where you could sit and maybe read or look over picture books or photograph albums. He would like to do that.
Well, it's very important that an Alzheimer's person actually still stay engaged in life and participate as much as possible. So if there are family activities that they can go to, that they can have some interaction with their grandchildren or their children or close friends, we usually advise them to keep the groups small, 1, 2, 3 people, not have lots of people or lots of stimulation. But we would encourage them to continue to have social relationships and to participate in activities that they used to enjoy with somebody.
Going out to dinner, what to expect. One may have to do things for them, such as order from the menu or make suggestions rather than to let them initiate their process. They may have to have help with their eating. They may be messy when they eat. There may be certain restaurants that would not be appropriate for them to go to. They may have limits in terms of their interest and endurance. A long shopping trip may not be possible anymore for Grandma. Maybe just a short trip. Maybe just going to church is all that she can tolerate. But she might enjoy going out for an ice cream cone rather than a whole meal.
Social life and social activities change with Alzheimer's disease. When the person is initially at home, many families find that they have to shorten visits out. They have to shorten exposure to large groups of people, or they have to limit exposure to smaller groups. Many families find that it works best to go out like as a couple with another couple where one member has Alzheimer's disease, and they can go out for a meal, they can go to a ball game together, and if the behavior's a little odd, they both have it and no one's upset about it and they're more tolerant than going out with their old friends. One of the things families complain the most about is that their old friends withdraw. And they think, well, he doesn't remember me, there's no point in me visiting. And they forget that the well spouse remembers well and really needs that adult conversation and companionship. In general, social activities become a little bit more structured and a little less cocktail party-like. For one thing, people with Alzheimer's disease can't tolerate alcohol, and it tends to increase their confusion and decrease their ability to function. So alcohol is pretty much out, and some of their traditional activities may need to be adapted. For example, people who like to play tennis may not be able to play competitively or keep score, but if you can find someone who will hit balls back and forth with them, they may be able to do that and enjoy it. The same thing with golf, with fishing. In general, the activities that work the best are adult-like, meaningful, and purposeful. So most people like doing familiar routines that they can still do in an adapted way, drying dishes, sorting laundry, folding laundry. One woman I worked with was a realtor. She was mute. She was unable to use any expressive language. We gave her a legal pad, and she started making lists of closings and things she had to do as a realtor that were perfectly legible and readable. She just couldn't verbally express those. If you gave her the props of her former identity, she felt reassured and dignified. And as long as she had her yellow legal pad and her pencil, she was fine.
I know some people, family members, who carry cards with them when they go to restaurants, and the cards say, "I'm with a person who has a memory problem," just so that the waitress will address most of the questions to the caregiver and not to the person with dementia.
She loved to ride, and that was something that we could do up until the point she was unable to do that. So she would take a drive, and as the dementia increased, she wasn't as anxious about going out. Before, she would really give us a hard time, and she didn't want to do anything out of her routine, and it was hard to encourage her. But as the disease progressed, she really became better and more manageable because she was willing to do whatever we wanted her to do. So it was kind of fun to be able to take her, and whether it be to the mall to get her picture or just for a drive.
She has her own small space that she's used to dealing with. She has her spot on the sofa that is hers. And if someone else walks in the room and sits in that spot, she just doesn't know what to do. She just stands there and stares and waits for him to get up and jumps back in it, So having company is very difficult. We have done it with a few very close friends, our family, but that's about it.
So families learn to adapt activities. They learn to use familiar work activities. They learn to identify what's called pleasant events, things that people seem to enjoy, and then time them to fit the attention span of the person and give as much direction, cueing, or supervision as required in order to do them. But they learn that they have to adapt visits, that large parties, that lots of noise, that multiple conversations in the same room become real tough for a lot of folks. Also, many people with Alzheimer's enjoy the same kind of entertainment they always enjoyed. For example, classical music concerts. They may very much enjoy going to a concert. They may not be able to sit as long. They may speak inappropriately at times and need to go out for a while. But they still may appreciate the opportunity to attend.
Alzheimer's changes almost everything about the reality in which our loved ones exist. And yet for many, their spirituality can still play an important part in that changing reality. And it can become even more important in sustaining those of us who are caregivers and carrying a burden that never seems to end.
It's real hard to tell for me whether she's getting anything out of church at all anymore. For a while, I'm sure she did. I think if nothing else, it's part of our routine that we've had all of our life. And as much as you can keep things routine, that is beneficial.
When our pastor would come to give him communion, he would accept it and seem to understand. And then later on, as the disease became, reached end stages, he didn't seem to understand what that was. And if you would give it to him, he would be pushing back, So I think he lost the comfort of that to a great extent.
One of the day programs that we took her to in the very beginning was a program conducted at the Jewish Home for the Aged. And I think that because of the rituals that were provided there, they would have Friday services, that I don't know this for a fact, but I like to think that that did give her some comfort.
A lot of our patients have very strong spiritual beliefs, and this may actually be something that is helpful in helping to work with a person with Alzheimer's disease. It may be talking to them about prayer, or asking them to pray with you, or using religious songs or service, or referring to the Bible may have a calming effect or help you as you work with an individual with Alzheimer's. I heard of a story of a gentleman who really had not been able to put two words together for some time, but he had been a former minister. And so they sat down at a table and they asked him to say a prayer. And he, for the next 3 minutes, said a very complete prayer, amazing everybody because he'd not been able to put several words together. Songs are also very important. People may be able to continue to sing portions of songs, and religious songs may be part of that, long after they're able to put words together. They recognize the music and they recognize the songs. So I think using their spirituality to comfort them and to communicate with them is a really important strategy.
I found that she could recall various church hymns that we would think, how in the world would her memory, but her remote memory, of course, and recent memory were quite different. So the words to the songs she would remember. She had her Bible there on her coffee table. But as far as reading it, I think as the disease progressed, she got beyond that. She enjoyed, though, if one would read to her, and I think she could comprehend somewhat what we were saying. And I think that was a nice activity for her.
First thing I remember about my mother is singing to me, and that she would sing these old hymns. So I tried to remember old hymns. So I started singing, I come to the garden alone, and the dew is still on the roses, and it goes, and he walks with me, and he talks with me. So I sang a bit of that, and I saw her move around. I thought, oh, great, that's wonderful. She kind of flickered her eyes, and so I sang a little bit more of that song, and she opened her eyes and looked right at me. So I thought, this is great. This is wonderful. What's the next hymn I know? Well, one of the things my mother and I thought about was I didn't go to church for a long time, so I didn't have a large repertoire of hymns to sing. So I remembered another one, and I started singing a song, on a hill far away stood an old, and I couldn't remember what was on that hill. So I tried it again. Because, sometimes you get it going by just singing it a little bit. On a hill far away stood an old, and I didn't get it. So I did it one more time. On a hill far away stood an old, and she opened her eyes and said, rugged cross. And in that moment, she was 100% my mother. Because what she said by saying rugged cross is, honey, if you'd been to church in the last 25 years, you would know the lyrics to this hymn. And I had this sense of everything between my mother and I was resolved in that last half hour together. The conflict about lifestyle, I was able to give back through her in a way that was meaningful to her, and she was able to relate to me. So I do believe, although this is a devastating disease, there's a way as someone who loves someone with dementia that we can continue to reach through this fog and make the contact and to give the love.
In the back of our minds, we know the day will probably come when it's time to go, when we can no longer adequately care for our loved one in the home and should let professionals in a care facility take over. That knowledge doesn't make facing this day any easier. Having other knowledge, though, can be very helpful at this time of transition. Knowing, for example, how to recognize when it's probably time to make the move, and even more, knowing what to look for in a facility that can provide the kind of care that our loved ones deserve and the kind of care we would give ourselves.
I've really been struggling with that one recently, with how we would handle and at what point the decision is going to have to be made that I can't take care of her anymore. I said all along that when she couldn't handle bathroom function, that was probably going to be it when we got to diapers. I don't know. I have just kind of been taking it a day at a time. In some ways, I think, I know that she will hate it at first. She will absolutely hate it if she's taken to a home. I have heard several people tell me that once they get used to it, that they like it, that you have to get through that transition period.
There's going to be a time in any caregiver's life that the individual they're taking care of, they can no longer do that. That's recognized usually by somebody outside the family. Because if it's a spouse, they don't want to, they've told the spouse, I'm not going to put you in a nursing home. Or that they've had a relationship with either a mother or a daughter that they've made a, quote, a promise to them. The problem with those promises is that if that caregiver's ability to take care of that individual goes down, then that individual's health will go down. That's the hardest thing for me to try to explain to someone.
I look for a place for my loved one who has, if I'm looking for another residence, I would want to look at both assisted living and skilled care. Particularly as the disease progresses, if the person has any kind of behavioral symptom, I would be looking for a special residence for people with dementia. In the early stages, when I have trouble handling my checkbook, cooking for myself, maybe remembering when it's time to take a bath, I could live in a generalized assisted living building, or I might even be able to stay at home with home health or some companions coming in. But as the disease progresses, I'm really going to need a physical environment that's designed to help me be successful. And I would check both assisted living and skilled care.
Some people see that there are a lot of benefits in dementia-specific settings that are designed just to meet the needs of folks with memory loss. And they're very satisfied with those settings because the staff training is better and the staff relationships are better. And sometimes there's consistent staffing, which makes a big difference in quality of care for people with Alzheimer's. They can't get used to new people and new routines. So to the extent that they see the same people on a regular basis, they will do better, particularly if those people are trained. Many families also look for places where the environment is set up to be attractive to their relative, and the environment is personalized. Many families appreciate the opportunity to decorate a residence room with something that reminds them of who they are so they can find their own room. Often that's not the newest possessions they have, but the oldest pictures they have of them from a time that they can best remember. So to the extent that the facility is open to family involvement, that lets the person personalize their environment, that seems to establish good relationships between staff members, frontline staff members, and the people they care for, where families seem to be pretty comfortable, those are generally good facilities.
We decided, based on her no longer able to dress, couldn't really feed herself at this point, not able to walk well, and she was incontinent. That's when we said, it's time. That was the most difficult experience out of it all, like so many families have, to come to that decision. And again, as a professional who has worked with families for 10 years now, helping them, counseling them in this decision-making process to find myself in that position, I responded just as they did over the years. A lot of it is denial. No, it's not time. We're fine. So much guilt. When is it right? Could I do more? How could I change things? We experienced all of that. So the emotional battle was difficult.
It's a very difficult decision. It's a very traumatic decision. For the most part, people will talk about it, and that's my own personal experience, as the worst day of your life when you have to literally place someone in a long-term care facility. But people are well cared for in long-term care facilities. There are a lot of facilities and a lot of assisted living and nursing home facilities that are really very, very good, and they may be actually taking better care of the person with Alzheimer's disease than you could have at home. And it's important to understand that no one is going to take care of your family person or your loved one like you did, because that's a unique relationship and it's a personal relationship. But it doesn't mean that the person, if they're in a facility, won't be well cared for, loved, respected, honored, and well taken care of.
So what we see generally is a very burdened family taking care of an older Alzheimer's victim as long as they possibly can, and in the later stages of the disease, giving them up almost in an emergency move to a long-term care facility without much planning, without much forethought, and a lot of ethical concerns are raised by the family. Do they want their loved one to live like this? Do they want to tube feed them? Do they want to just let them pass away as soon as possible without trying to prolong an agony that is a very real one for both the caregiver and the Alzheimer's victim? And the counseling involved at this stage is tremendous, and families all have different desires for their Alzheimer's patients. Some Alzheimer's patients have previously expressed advanced directives such as living wills. Sometimes it's a further burden to the caregiver to try to make the decisions as to how best to care for their family member when they can't make their own decisions. And they sometimes have to negotiate that decision with other family members who may not be very kind in their relationships with the caregiver.
By the time placement was ready to happen, our family was not speaking. And because I actually worked at the nursing home that she was in at the time for her therapy, I was the one to do it. And I remember that day so vividly, getting her out of the car and putting her in the wheelchair and rolling her in the front door was the most difficult. Behind her, I couldn't control the tears. I didn't allow her to see that naturally, but it was pervasive, the sadness and the grief and the fear of allowing other individuals that I hardly know to care for my grandmother. And then answering to my family, did I do the right thing? Are we doing the right thing? What if something happens, then it's my fault? So that was a major struggle.
Families have to be vigilant in assessing the quality of care of their loved one when they're in a facility or when they're being cared for by a paid home care provider. They can first assess what seems to be the relationship, how the staff person responds to their relative, how they treat them in the family's presence anyway. They can certainly look at the physical appearance of their relative, if they're expected to provide personal care, or are they clean, well-groomed? Do they seem comfortable? Do they seem frightened of the staff person? Do they seem withdrawn or apathetic around the staff person? Families need to be vigilant about the use of physical restraints in nursing homes. We know that physical restraints can cause more problems than they solve, and they are much less likely to protect a patient than they are to injure a patient. Some nursing facilities may make overly liberal use of sedative drugs to make people easier to care for, but they can induce a host of side effects and other problems that families may become aware of.
As I visited, I saw them responding to my grandmother, the CNTs and the nurses were so loving. They loved her because she's so precious, and she had developed a rapport and with the staff, and I would walk in and find them hugging her and kissing her, and I can't tell you what that did for my morale and for my peace of mind. And it's so often that we see nursing homes as places to leave mom or dad that are not nice and loving and kind, and the media tends to exaggerate the negative. But I found so much positive opportunities. These are staff that sleep at night, that get up, that shifts where they are ready to do it the next day, whereas our family did not sleep, was not able to do that long term. We had other team members who worked with us to make that happen, and we developed that trust. And no, it's not perfect. It still isn't. She's in a nursing home. She's still there now, and I still feel as good about it as I did several days after she was placed. It's not home. It is different. It has been a transition and a change for all of us. But if I had it to do over again, I would not change one thing.
The average person suffering from Alzheimer's lives between 7 and 10 years after being diagnosed. The final result is always the same. And yet, even though we know that death will come, this last transition can be the most difficult of all. Caregivers feel like they've spent a lot of time saying goodbye. And yet at the end, the heavy physical burden of caregiving can be replaced by an even heavier emotional burden.
As it got to the point where she was losing more and more abilities, it upset me from a lot of different angles. The typical one of losing her, but also, quite frankly, what that was going to mean to me, and the constraints that it was putting on my life. As it moved on and on, I remember right before we made the decision to place her, I just became really upset in terms of, God, what kind of a life is this for her? She is just deteriorating. And I would be encouraged by other people that, the message that she had had a good life, but that didn't really help. And then, of course, the very end was the most horrible. And that, quite frankly, is the image that sticks in my mind, is the very end.
Grief and bereavement issues are very different in Alzheimer's disease because there's a prolonged anticipatory loss of the person as you once knew him or her. And particularly when the person starts not to recognize close family members as family members, accuses, you're not my real wife, I don't have any children. Those sorts of things can be very hurtful to a wife of 60 years who has basically devoted her life to caring for her husband. At points like that, what seems to make the most difference for families is not being abandoned by other friends, relatives, church community, people who are important to them. This is when they need the most support, when they need the most reassurance of who they are and that they are still part of a couple, and that it doesn't in any way diminish the success of their marriage or what they did accomplish as a couple or as a parent-child relationship. They need to be reassured in whatever they find comforting. For many families, when bad things happen to good people, they turn to their religious faith for explanations, for comfort, for reassurance, and that can be very effective. Some families are very disappointed in the response of their church communities. They find that their churches can mobilize very well for short-term illnesses, but a prolonged bereavement period that is experienced by people with relatives with Alzheimer's disease is really difficult. for many churches to sustain that kind of support over time. Many people do well with it. Their Sunday school classes stay with them throughout the course of the illness and keep reminding them that they are connected to a group of people who remember them when they were able to function better.
It's like any disease process, the first thing that hits us is denial. And with denial, that just can't be what's happening to Dad. Dad's been such a highly educated man. He's always been so capable. That can't be happening to my father. And that's the time that the family members need the support of other people. That's why the Alzheimer's Association's free support groups are so important.
A lot of times families grieve the loss of their loved one when the loved one is still alive. When a person has Alzheimer's disease, they watch them lose the essence of what made them the person they loved. Their personality changes. Their memories are gone. Their shared memories are gone. You can't even sit down and say, oh, remember when we did this, or remember when we did this. That's maybe completely blanked out. So their life together as they knew it is just gradually slipping away. And a person often will describe that by the time the person passes away with Alzheimer's disease, they've really gone through the grief process. They've grieved them while they're still living. It's such a devastating disease that robs a person of their personality.
In many cases, we will find that the caregivers can become clinically depressed, if you will, because that grieving process goes on so long. And when the person finally passes from the disease, many times we will find that the grieving process continues. They may anticipate that what they're going to experience is some relief from having the burden of taking care of somebody. And actually the opposite may happen, and that they realize that the loss is now final, and that there continues to be a very intense grieving process.
And I hoping that having grieving when she was alive, I will grieve less when she passed away. But I remember very clearly the day after she passed away, we all went to my mother's house to discuss how we're going to do the funeral, do the service. And my mother has prepared a picture of her, which was taken a few years ago. It has been enlarged, being prepared for this occasion, which I find was kind of odd. But apparently in our culture that before a person passes away, you get a picture ready, you get clothes ready. So even the last few days in the hospital, my mother brought the clothes into the hospital, and I was so upset. I yelled at my aunt, who reminded my mother to do that, and I told them to take it away. But I remember I saw the picture. The moment I saw the picture, was smiling on the picture, because remember for 3.5 years my grandmother was expressionless in her face, and I just burst into big cry, because I said I feel like I made my grandmother suffer all this year to live in this shell, this body, really don't know whether there's a soul there, and all for myself, selfish reason, because I didn't want to let her go. I've been holding her for so long, because in reality, many times if we didn't rush her to the hospital and take care of her this much, because the whole time was from 7 years since diagnosed, but before that 3 more years, about 10 years, maybe even earlier. And I feel it was just, she lived for us, because I want her to live. But then she's really living in the quality and the form. If she could speak, she would say, "Tammy, let me go." But I didn't realize it until when I saw the picture. I realized that was her. I forgot what she was like, how lovely, how beautiful she was, until that moment. And I was so angry at myself that I was so selfish all this year. And I told myself, how come I didn't let her go? And that was, and although when I was taking care of her, I was proud of doing everything I can to give her the best care. But until when I saw her picture, and I'd say, I was selfish. I just want her to live for my sake, not for her own.
Many families are also surprised at the intensity of their grief and bereavement at the time of the death of the person with Alzheimer's disease. They think, I've been grieving this person for so long that I didn't think I would have this powerful a response. But basically what they've been doing is centering their lives around caring for this person, and there's this huge void when they're no longer there, even if they haven't recognized them in years. One man told me, as long as my wife is breathing next to me, it's kept the widows from my door. And he was terrified by his new status. Many people find that their grief reactions with nursing home placement are also rather intense. It does imply an irreparable loss of a relationship in a way that they knew it. Spouses particularly feel a limbo status. They're married, but they're not recognized by their spouse. They have a husband, but he's not with them. And they don't know what is a socially appropriate role for them in those situations. Many spouses visiting their spouse in a nursing home find each other and get a lot of comfort from the other visiting spouses in an existing nursing home, and a way of dealing with their grief in those just visiting situations. Some nursing facilities do set up their own support groups for families of people with Alzheimer's disease. Some families find that they become most active in support groups after placement of their relative because they're at loose ends. They have all the responsibility and none of the control. And many people find that the most difficult transition in care and the most difficult bereavement issue. Again, other people find that at the time of the death, there's this expectation that they're going to be fine because they've been prepared for this for years. And they find that they're not fine. And they still need to go through the grief all over again.
When the Alzheimer's patient dies, the surviving family members, the caregivers, often are relieved and feel guilty about that. They now have their life back, but their sole reason for living often and their constant effort is now gone. And sometimes they have a reaction that requires help as well. They may be depressed, or they may feel like they need help now to be taken care of. If they do feel good about their newfound time and freedom, they sometimes are guilty and depressed about that, so they need help.
Some people find groups for widows and widowers helpful. Some people become active as advocates for the Alzheimer's Association after their relative has died, as a way of channeling their grief into a meaningful community response. Some people find that they reinitiate activities that they used to enjoy as a way of dealing with their grief. Other people are fortunate enough to find new partners and new intimacy outlets that turn out to be very significant in dealing with their loss.
And that evening, after I had gotten home, they called me from the hospital, like 8 o'clock, and he had passed. So it was sort of a shock, but it was a shock that it had happened then, but yet it wasn't a total surprise because I had felt sort of like it was coming, you know. And I was able to drive. I went to the hospital. My pastor met me there. And as far as the grieving, I felt like, I guess I was kind of numb for a while, but I felt as though he would not have wanted his life to continue in the state that he was in. So perhaps this was a blessing in disguise. So I was able to handle this outwardly pretty well. At home, I had bouts of weeping by myself that went on for quite a period. I guess maybe sometimes on the odd occasion I have it now, but I got over that. But you just know that you have to go on with your life, and you're grateful for all that you did have.
Someday, we hope, I believe, there may be a cure for Alzheimer's. Researchers are working on all kinds of things, and they believe that if a way can be found to delay the onset of the disease by just 10 years or so, well, Alzheimer's would be virtually wiped out. As the research continues, and as we learn more about the human brain, hope will only grow. As we anticipate that day and pray for that day, remember, you are not alone. There's always help, just as there is always hope.
The emotional aspects of caregiving can be extremely complex and uniquely personal to each individual. But in talking to caregivers, we have found they have many concerns in common. In fact, coping is the one topic that seems to be the most difficult for caregivers.
But I think as a nurse, I also feel like I should be able to do a better job of what I'm doing. And I don't mean the physical kind of things, but I mean dealing with the emotional part of the role change and the emotional part of seeing my mother declining.
To sit down and make a list of, these are the things that I feel comfortable with, that I feel like I'm handling okay, and these are the areas where I'm feeling overwhelmed.
Feeling confused and pulled in several different directions is a common complaint from caregivers. Demands from work and family, plus those created from the caregiving process, may make you feel like you're not able to satisfy everyone or anyone.
I wanted to please her, and I wanted her to be happy, and I wanted her to feel well, and when I couldn't make her happy, it was just very difficult for me.
Because it's not his fault and it's nobody's fault. But you're angry because you say, why? And some days that he's more confused than others, and you lose your patience because you need a lot of patience with this disease.
People really set themselves up for physical health problems, mental health problems, when they try to do it all themselves. And it's a very dangerous position to be in because ultimately you're putting your loved one at a greater risk.
I was really becoming emotionally exhausted, was that I couldn't do the things that I love to do, and I had all this time to do it. I had all this free time to write, read, create, and I couldn't do it.
Before you can take care of someone else, you have got to take care of yourself. You have got to get up and, as much as you can, at least have that shower, get dressed, and a few minutes to yourself before you can take on the care of someone else.
Profound levels of self-care are needed in order to continue caregiving, and hard decisions like putting yourself first becomes necessary in order for you to do anything at all. And I think it's really hard for persons to make that switch and to realize that, in fact, what has all along been seen as the non-loving thing to do is now the most loving thing to do. Because if you can't maintain your own strength, then you can't be there for that person.
Whatever matters a whole lot to the individual to whom the care is given. And if it is not endangering his health, that he ought to be permitted to do it, even though the observer would think that it was stupid for him to do that, that it was childish or selfish or whatever. And you would think of it that he would have only some X number of years to live, and he might as well live those happily.
Fold each side of the washcloth across the palm of the hand. Now, fold the top of the cloth over the palm and tuck it under the edge. Using long, smooth strokes, wash from the wrist to the upper arm. Then bend the patient's leg on the bed and place the foot in the wash basin. Place the shampoo basin or inflatable sink under the patient's head. Using a pitcher, completely wet the patient's hair. Use warm water ranging from 105 to 110 degrees Fahrenheit. Select bedding that is lightweight, soft, and washable. Synthetic fabrics are often too hot. Starting at the head of the bed, strip the bottom sheet, draw sheet, and linen-saving pad from the unoccupied side of the bed. Roll the sheet tightly against the person's back or side. Bedridden patients should, if at all possible, be placed near a window with a view. Also place a large calendar and clock in the room. Devices like a mechanical lift can relieve much of the physical burden. First, let's learn how to safely transfer a patient from the bed to a chair. Bring your forearm to your chest, drawing the patient to you. Hold the patient's inside hand with your outer hand. This position gives you good control of the patient. Observe your home with a fresh eye for obvious dangers. You may also want to purchase a waterproof bench or chair to place in the shower or tub so the patient can sit while bathing. Always speak to the patient as an adult in a clear and respectful manner. Also, talk to the patient as if you expect a response. Many patients can understand what you're saying, even if they don't respond.
I think everyone should have a list of all the medications they're taking, what is prescribed by the doctor, have the trade name, have the generic name written down.
Number 2, when supervising or administering medication, check for the 5 rights: the right medicine, the right dosage, the right time, the right route, and the right way.
One of the most important things that a caregiver can do, or any patient can do, is be familiar with your medicine, with what it looks like.
Single, most effective way to prevent infection is as close as your sink. It's called hand washing, while turning the glove inside out. With the inside out glove protecting your fingertips, peel off the remaining glove, turning it inside out and encasing the first glove. Always use disposable gloves when touching soiled linens, pads, wound dressings, or clothing. Nutrition plays a vital part in maintaining good health and preventing and treating disease. However, most caregivers soon realize that ensuring adequate nutrition for the patient can be somewhat challenging.
More often than not, families postpone the decision to look at long-term care until their loved one experiences a crisis or can no longer take care of themselves. But the best time to explore your choices is well before you're forced to make them.
I cannot emphasize enough the kind of communication in which we learn the wishes of the individual for whom we're caring.
There are a number of warning signs you can watch for. One term you'll hear frequently is ADLs, activities of daily living.
Another trigger may be that there is particular, what we would classify as bizarre behavior.
The children are in denial that dad needs help or mom needs help. And most of those classic examples are usually people that have memory loss and Alzheimer's type dementia.
It's important to have that assessed and not just assume that they're getting old and so their memory's not good. That is not true.
We're all bounded by limits from the standpoint that even though we see need, even though that we see unmet need, that we may have to start not with level of care change, but start at a lower level with what a parent will accept.
Determining which option is best for you depends on several factors. First and foremost, the extent of your loved one's physical needs and abilities, your family's financial situation, and your loved one's preferences and your own.
The good news is that families have lots of options today. The bad news is that there's often some confusion on what those options really are.
Simple medication instruction, teaching families what are some of the side effects of medications, what are the usual schedules for medication.
There are a lot of devices that help people still continue to use their hands that have aged and aren't as strong as they used to be.
There is no shame in looking for other settings and other relationships.
Talk to your loved one in a respectful way that makes them feel part of the decision.
If you and I were uprooted in the midst of having medical problems from a home that had many memories that our children grew up in, or that we had very special things that to us were a part of our memory and history, and all of a sudden we were plopped somewhere else, it would be a catastrophic kind of reaction in a grief.
If you are truly at a place where you can no longer provide the best care for that person, you're making the most kind, loving, and ethical decision to go on to the next step. And your responsibility there doesn't end, but it changes.
Many times you hear about guilt on the children's side of things when they move someone to assisted living, but a lot of times the resident also had guilt by feeling like they may have been a burden. The biggest difference between independent living and assisted living would be someone that might be ready to make a change. Maybe the water heater's gone out for the last time. There's quite a few widows and widowers that, especially the widowers, that were not accustomed to cooking for themselves all the time, and just like the support services.
And the biggest word of advice we have for couples, a husband and wife, that are looking to move out of their home and into some type of a community.
In an assisted living community, residents receive the help they require with activities of daily living.
Aging in place assumes that we build in the support that's needed in an appropriate fashion as conditions and as the aging process itself present opportunities to make life better for that individual.
There are two levels of nursing care, and many facilities offer both. Skilled nursing care.
Be very picky. Be very picky. It's very difficult to make that first move. It's even going to be more difficult to make the second move.
But it's also important to go at some unscheduled times, because you want to see what's going on in the evenings or what's going on the weekends, because typically staffing patterns are different.
There is no substitute for a loving, trustworthy, empathic individual.
How they structure their day, what kind of activities they have, what kind of staffing ratios they have. Do they have a nurse on site? How do they handle emergencies?
At the same time, they want the CNAs in the facilities to realize who they're dealing with, that this is your husband, and he was a banker, and he loved to ski, and to humanize your loved one.
The pharmacies usually will package it in what they call bubble packs, and to find out maybe they cannot swallow certain types of pills or certain capsules, or can they be opened up and put into Jell-O or to applesauce. If that's what was done before at home, then maybe that's what you need to be able to emphasize also to the people at the facility.
They still know their family member better than anyone else, and that, in fact, it is their responsibility to maintain an alliance and a partnership with a care facility.
Nursing homes are the most highly regulated healthcare industry in this country, and they have very stringent requirements related to that. However, that does not always translate to high-quality care.
They need to be very bold and very specific in knowing what's going on in an environment where a loved one is placed.
Many Americans are looking at long-term care insurance as a way to preserve choice, protect their assets, and reduce the burden for family caregivers if the need for care arises. Medicaid is a joint federal-state health financing program for low-income individuals.
Depending on a person's age and their sex, their health, they may live many, many years needing some type, if not complete, long-term care. So having that insurance policy for peace of mind, if nothing else, for many people is quite helpful. Many children are beginning to look into long-term care policies for the same reason.
Some people think that buying long-term care insurance can be quite complicated, when in essence there's basically 5 decisions that you're going to make.
It's important to have a comprehensive policy that offers benefits across the care continuum, meaning home health, other community care such as adult daycare, assisted living, skilled nursing facility, who knows what will come in the future, whatever the continuum is, so that the person has choices, because really the crux of long-term care insurance is asset protection and independence and choice.
Then that policy is going to allow their caregiver at home to have help come in on a regular basis to give them the relief they need to provide care for that individual for a longer, more extended period of time.
There are 3 important legal instruments that address these issues: a testamentary will, a living will, and a durable power of attorney.
Now, in almost every state, even if there's no will, the property is going to pass to the spouse and then the children. It won't go to the state, which is what a lot of people are afraid of. Oh, if I die without a will, it's all going to go to the state. Property only goes to the state.
The living will is really a communication device to your family and to your providers, healthcare providers, your doctors and others. These are my wishes. I'm writing this down and putting it in a form that I want you to respect.
80% of people who die in America die in the hospital. Many of those deaths occur in intensive care units. Some of those deaths, about 15% of them, occur after the patient their heart has stopped and we've attempted to resuscitate them.
A durable power of attorney is another important means of making sure your wishes are followed.
A durable power of attorney for health care is another legal instrument that allows a person, whether they're terminally ill or well, to identify another person.
It is a good idea for people to have the living will, the durable power of attorney for health care, and the general or financial power of attorney to cover all financial matters.
Generally speaking, when people get to the place where they have to make decisions about long-term care, financial decisions are the last thing that they want to be dealing with.
It's almost a skeleton binder that the parent or the child can have as a starting point to say, I've got to find this document, I've got to find this document, and it's a place to where you can store everything.
You don't immediately assume that what you're looking at is simply a document. It may actually be the asset itself.
How much will you need to spend? To answer this second question, you'll need to do a little legwork.
What most people end up dealing with is, how do I make my money stretch far enough?
For most of us, Social Security is the first financial resource we think of when we plan for our retirement years. But the benefits are not the same for everyone, and not everyone qualifies to receive them.
The spouses may want to check and see whether it would be more beneficial to draw their normal Social Security benefit.
In the distribution phase of a retirement plan, you really have to be aware of the income tax associated with each retirement account. The money that is set up for the fixed income side is set up in a way that you have a consistent flow of income, whether on a monthly or a quarterly basis, to where you can keep up with the inflows.
Part A pays for hospital care. a limited amount of nurse. Medicare Part B pays primarily for physician charges, though it also covers. Medicare benefits are based on a complex table of charges that the government believes are reasonable.
When a physician accepts assignment under Medicare Part B, they are accepting the Medicare-approved charge as payment in full. But a Medicare summary of coverage basically gives you an explanation of what charges the doctor has charged based on the given procedure. In addition to traditional Medicare, the federal government has created Medicare Choice.
Since Medicare doesn't pay for everything, many people buy supplemental coverage.
In the early 90s, the federal government standardized those plans, and there's now 10 plans.